Hi, everyone. It's a pleasure to be here, and thank you for joining us. My name is Dr. Rebecca Spiegel, and I am the chief of the Stony Brook Comprehensive Epilepsy Center. And today's topic is actually going to be centered around epilepsy. We'll be discussing advances in the diagnosis, in treatment, and support that we can provide our patients with epilepsy. And it's a perfect time to talk about it because November is the Epilepsy Awareness Month. And it is my sincere pleasure to introduce my colleagues and the three fabulous panelists we have for you today. I will start with alphabetical order. So I'll start with my colleague, Dr. Lourdes Bello, who is one of our pediatric epileptologists. So welcome, Dr. Bello. And the next on our list is Dr. Benjamin Blond. Dr. Blond is actually both an adult and pediatric epileptologist, and he's also the director of our epilepsy surgical program. So welcome, Dr. Blond.
Thanks. It's a pleasure to be here.
Great. And last and certainly not least, I would like to welcome Dr. Luis Manganes, who is the chief of pediatric epilepsy in our comprehensive center. So welcome again. And also, I just wanted to let you know for the audience who are joining us, there is a comment section. So by all means, put questions as well. And just in case we are running out of time, consider putting your email as well, because we would love to answer your questions. So if we don't get to it, for whatever reason, it would give us a way to still answer back. Okay, all righty. So we'll start with you, Dr. Bello, okay? And the first question that many of my patients have asked for the first time, particularly if they had a single seizure, and here they are coming to see me, and I'm sure this question has been asked to everybody here, is if they come with a single seizure and they ask, hey, do I have epilepsy? So when they ask you that question, Dr. Bello, what do you answer?
First of all, thank you for having me. Well, what I usually tell people is that a seizure is usually a burst of uncontrolled electrical activity between the brain cells that have many causes, and it causes temporary abnormalities in the muscle tone of movement of the body, and as well as other changes on behavior, sensations, or a state of awareness. Not all seizures are alike. They can be different in the same patient, and they are not always related to epilepsy. They are a symptom basically of disruption of function in the brain, and they can be caused by multiple things like high fever, head injury, transient lack of oxygen, and it doesn't necessarily mean that the patient has epilepsy. Like one single episode can resolve without ending being an epilepsy. And up to 10% of all Americans will experience a seizure in their lifetime. The highest incidence being at a very young age, around 2, early infancy, and over the age of 65. Now, in the other hand, epilepsy means to be a chronic recurrent disorder where the patient is prone to have several seizures that can be caused by genetic factors, structural abnormalities, changes in the metabolism, and that can begin at any age. It can also start as during a major event like infection, trauma, tumors, and remain for the rest of the life. So in those cases, we call it symptomatic epilepsy. And sometimes, unfortunately, despite all the studies, no clear cause is found on the initial testing. And that's when we played a role as epileptologists, trying to find out what the reason or the cause for the epilepsy is about.
That's great. Thank you. And other than the history, the clinical exam, some of the audiences may want to know in terms of the typical workup, at least the beginning, of in terms of diagnostic modalities, what should one expect?
Yes. Initially, as any other patient with any other condition, a complete medical examination is necessary, trying to figure out if there's any underlying cause. And then a number of tests that are essential to try to figure out what the cause of the seizures, the epilepsy. It includes an EEG, but basically it's a test. And probably many of you have seen that, consists of putting leads in the head that measure the electrical impulses in the brain. There is also an MRI, basically in plain language we can say, is taking a picture of the brain. And this technology has evolved because many years ago we had the CAT scan and now the MRI that is more detailed, trying to clarify if there are any structural abnormality. There are some additional tests that can be requested for any specific individual, including blood work, looking for specific conditions. In childhood, we try to exclude like metabolic disorders, and then we also get the help of other specialists like geneticists that sometimes they order some additional testing. Nowadays, there are many new ways of trying to find out where the source of the seizure is, and there are many sophisticated images modalities that can be used. But again, it is used in complex cases.
Great. That is very good. Thank you. So we are starting to get an understanding of the diagnosis, what's involved. That was very comprehensive. Thank you for that, Dr. Bello. So my next question is to Dr. Manganes. And Dr. Manganes, I was wondering, here we are talking about some advances that are occurring in our field. So in the realm of medications, if you can just tell us about recent medications that have been approved.
Well, thank you, Dr. Spiegel, and thank you, everybody, for joining us today. So medications for patients with epilepsy and seizures are constantly being discovered and constantly being designed. So there have been medicines used for epilepsy as early as the ancient times when ketogenic diet, as what we know today to be the ketogenic diet, was used. But over the last 100+ years, anti-epileptic drugs have been designed for this purpose. At this moment, we have close to 30 anti-epileptic drugs that are on the market, first generation, second generation, and more recently, third generation. And over the last 2 decades, I would say greater than half of these medications have been approved. And keep in mind, anti-epileptic drugs or anti-seizure medications, which we're now calling them, are really designed to prevent seizures. They're not designed to reverse the process of epilepsy, although there is an emerging field of anti-epileptogenics, which are now beginning to address this part of the process. But currently we are using anti-epileptic drugs. More recently, we've had at least 3 new anti-epileptic drugs approved. In 2018, Epidiolex was approved for anyone over the age of 2 with Dravet syndrome, tuberous sclerosis, and Lennox-Gastaut syndrome. And Epidiolex is the FDA-approved cannabis. It's organic, pure cannabis used to prevent these seizures, and it does so quite effectively, although mechanistically, it's still not very clear what the defined anti-epileptic mechanism is. In 2019, cenobamate was approved for focal seizures in people over the age of 18. Now, cenobamate is a sodium channel blocker, but it's not your traditional sodium channel blocker. It prevents or blocks presumably sodium channels or persistent sodium channels, meaning sodium channels that are always on, rather than transient or sodium channels that go on and off. So this is a different way of viewing your traditional sodium channel blocker, and it's been quite effective. And finally, in 2020, fenfluramine was approved for anybody over the age of 2 with Dravet syndrome. And mechanistically, fenfluramine works in a very different way by promoting serotonin release. And in doing so, has had quite a remarkable effect on patients with Dravet, which is a severe form of epilepsy that tends to be intractable. So those are the latest medicines that have been approved, but also in that time span, 2 other medications were approved, Nasolam and Valtoco, and these are rescue medications to use in anybody who has cluster seizures or seizures that are prolonged. Traditionally, we've used and prescribed rectal diazepam, but of course, although effective, there were some limitations and variabilities in administration. Now with the nasal formulations that have been approved, we are hoping that more and more people will have rescue plans, which will not only prevent seizures, prevent prolonged seizures, but prevent people from entering refractory status or prolonged epilepsy or prolonged seizures, which will lead to admission to the emergency room and increased risk for harmful effects. So we're very excited about not only the newer drugs that are being designed with newer mechanisms, but also rescue medications which will prevent people from injury and harmful effects of prolonged seizures.
Very good. Thank you. Okay. The next question actually I have also for you, Dr. Manganas, is at what point do we call epilepsy refractory, and what does refractory really mean?
Yeah, so refractory epilepsy typically refers to somebody who has recurrent seizures despite having been trialed on 3 medications, 3 rationally chosen medications at therapeutic levels. So if I have a child or an adult who has focal seizures or generalized seizures, and I've chosen 3 medications indicated for those seizures, and I've titrated those medications to acceptable or therapeutic doses, and despite those medicines, the seizures continue, then that's what we would call intractable or refractory epilepsy. In general, what we try to do in these cases is choose medicines ideally with 3 different mechanisms of actions. For example, you may start with a sodium channel blocker, then change to a GABA receptor binder, and then change to another medication that acts very differently, maybe preventing neurotransmitter release or such. That way, we know that we've done everything possible, not only from a mechanistic point of view, but also maintaining the fact that we're focusing on what that drug is being used for and that it is therapeutic. So refractory in general means that you failed 3 medications. We failed to control your seizures with 3 medications. Now, 30% of people will be intractable or refractory to to treatment with the medications that we have. And this has sort of been something that we've known for quite a long time, despite all the new medications that we in conjunction with the pharmaceutical companies have been able to design. We still cannot treat effectively 30% of our patient population. Although the side effect profiles of these medications has improved significantly, the efficacy or the rate at which we can stop these seizures still remains at about 30%, 25%. And this brings the whole notion of anti-epileptogenic drugs into the forefront, which again is a new way of thinking about seizure medications, and hopefully looking into this potential may address the 30% of patients who have intractable or refractory epilepsy, at least in the future as we look forward.
Great. Thank you so much for that. Okay. All righty. So actually, my next question is actually to you, Dr. Blond. Before we talk about surgical options, and some of our patients may actually benefit from surgical options if they are in this refractory state. But I know people may wonder, here we are mentioning that, we are a level 4 comprehensive epilepsy center. Thankfully, Suffolk County has that type of center with us. But what exactly a level 4 entails? If you can elaborate on that, and then I will be asking you about surgical techniques as well.
Sure. Well, I think, epilepsy really is a very significant and impactful condition for anyone, who has it. It has major effects on health and safety, but also learning and development and mood and behavior. And for that reason, there's a tremendous effort on the part of healthcare providers and researchers in creating epilepsy centers. And those are centers where there's really an expertise in the diagnosis and treatment of epilepsy. And there are different levels of centers that are out there and that are accredited by the national body. And to be a specialized epilepsy center, you need to have doctors who have undergone training, specifically in epilepsy. And there needs to be collaboration with other providers who have expertise in other things that affect epilepsy. So radiologists who are experienced at identifying things that can cause seizures that we might see in the brain, and neuropsychologists who understand impacts on learning and attention and mood, and also working with neurosurgeons. As you alluded to, there's different levels of epilepsy centers, and we are proud to be a level 4 center, which is the highest level of accreditation. One of the main things that distinguishes a level 4 center is the ability to do epilepsy surgery. So as Dr. Manganis was, talking about, thankfully with advances in care and medications, we are able to bring seizures under control in the majority of adults and children that we see, who have epilepsy. And we pride ourselves as a expert center in trying to be able to give the best chance of control. But in approximately 1/3 of people with epilepsy, seizures remain uncontrolled, even with the use of different anti-seizure medications. And it's in this group where we really think about what other things can be done, and where it's really highly recommended that people who are still having seizures despite the use of medications should be seen in a specialized epilepsy center and further evaluated. Sometimes the initial step is performing additional diagnostic tests to confirm that epilepsy is the correct diagnosis and that we don't have another diagnosis that looked like epilepsy, and that's the reason for not responding to anti-seizure medication. But often it is a person who has epilepsy that's just very challenging to treat, and that's when we'll perform a workup for surgery. For some people who have epilepsy, the reason that they have it is that there's a particular area in the brain which is causing the seizures. And that can sometimes respond very well to surgery. And sometimes we'll see that people who have failed many different medications can have a major reduction or sometimes even be cured of their epilepsy through the use of surgery. There are many steps involved in an epilepsy surgery workup. We perform a number of different tests that are designed to try to find, is there a particular location in the brain that seizures are coming from, and then trying to identify that as precisely as possible. And then we also perform additional investigations to learn about the health of that region of the brain. Often the reason that a person has seizures and epilepsy is because there's something wrong in that area of the brain. And that may mean that it's not really performing the function that it's supposed to, as well as causing seizures, which can sometimes provide an opportunity for surgery. If there's an area of the brain that's causing seizures and is not meaningfully contributing to the person's quality of life, then you can do a surgery where that area is removed. Or in some cases, we actually use a technique called laser ablation, which is a less invasive technique for getting rid of tissue that's causing seizures. In other situations, we find that a person may be having seizures coming from more than one place in the brain, or the seizures may come from a place in the brain that still is providing important functions for the person in terms of perhaps contributing to their memory or their language function. And those would be situations where it wouldn't be safe to do a surgery that removes or destroys some of the brain tissue. In those cases, there are 3 different neurostimulation technologies that are available. And those can sometimes provide a very dramatic reduction in seizures for patients. And in some cases can even completely stop seizures. And so there are many different things that can be done for people who are continuing to have seizures despite the use of anti-seizure medication. It can be a long journey and a lot of testing, but level 4 centers such as ourselves are experienced at bringing people through that journey and helping them with the decision-making process along the way. And ultimately, we can often find solutions that can help people improve their quality of life. And as I say, in the best case scenarios, can completely stop the seizures.
Thank you so much. That was great. Dr. Blond, actually, I have a participant who actually asked a very timely question about COVID. And can COVID, that was Ray, actually. And the question was asked if can COVID actually bring on seizures and possibly even epilepsy? I know there is limited literature, but if you can weigh in.
Sure. So, certainly COVID has affected so many aspects of our lives, and I think every type of medical professional, thinks about ways that, COVID has had an impact. But research does take time, so sometimes having very definitive answers can be tricky. I would say that we do know that infections of the brain can be a cause of seizures and sometimes can be a cause of epilepsy. In general, when an infection is a cause of epilepsy, the reason that it causes epilepsy is because it gets into the brain tissue itself and causes permanent damage to that brain tissue. And then that injured brain is what can cause ongoing seizures in the future. As far as COVID goes, we do know of cases where people have a very overwhelming brain infection called encephalitis. And that's where COVID is actively causing inflammation directly in the brain. And we can see damage on MRIs of the brain that is permanent. You can see it on follow-up. That thankfully is very rare that we've identified so far with COVID. You may know of other things that affect the nervous system with COVID, such as an impact on taste and smell. Some people can have headaches that have been triggered by COVID, and we may see some changes in the brain that end up going away and resolving on follow-up imaging. And those would not be situations where we would expect COVID to be a cause of seizures or ongoing epilepsy. So yes, COVID can be a cause of epilepsy, but right now it seems to be in pretty rare cases where there's significant, brain damage, and we're able to see that. I hope that answers the question. I guess I'll just add one other thing, that for people who have epilepsy, having any type of infection can sometimes make it easier to have a seizure in that moment because of the strain on the body. And some people with epilepsy are particularly sensitive to temperature, and having a fever of any kind, can sometimes increase the risk of having seizures. This is an area of active research, but so far it doesn't seem like COVID has a higher rate of aggravating seizures than any of the typical viruses. And so although there's many things about COVID that make it more severe than the average virus, and that's why it's impacted our lives so much, from an epilepsy perspective, it hasn't been particularly problematic for seizures for most patients.
Right. Thank you so much. That's great. Okay, so we talked about medications. We talked about some surgical options as well. And actually, the next question actually goes to you, Dr. Bello. Also, there are some diets that may help when it comes to controlling seizures. And I was wondering if you can expand on that, on the various diets that one can consider.
Definitely. There has been some diets that have been developed through time. And the one that we know the most is about the ketogenic diet. But there are some other variants that I would also comment about. And basically, the ketogenic diet is based on the fact that when the body burns fat, it creates substances called ketones. And then the ketogenic diet tries to force our body to use more fat instead of sugar. By increasing the fat and reducing carbohydrates, we achieve our goal. And then it can be used to prevent seizures in certain types of epilepsy. Essentially, one size doesn't fit all. It works for certain type of epilepsies. It is not clear how or why the ketogenic diet prevents or reduces the seizures in terms of a molecular mechanism. However, it has been successful to control seizures in many patients. Now, it is very restrictive, and that is one of the things that limits its use. Initially, when the patient is going to be started on ketogenic diet, it has to come to the hospital, be admitted, and then the diet is gradually introduced over several days so that the body can get used to the dramatic changes in the food. The person maybe feel tired at the beginning and lack of some energy during the first few days, but they go back to baseline. And when it works, the ketogenic diet quickly reduce the seizures, having fewer seizures in 2 to 3 weeks. So it's a gradual process. Now, because of the fact that it's very restricted, probably you have heard about modified Atkins and Atkins, that the patient doesn't have to measure the carbs and fats, and it has its advantages. It doesn't have the fluid or calorie restriction of the keto diet. Although the facts are strongly encouraged, they are not weighted or measured. And patients and parents have reported a success as good as if they were using a ketogenic diet. It can be started outside the hospital, and the patient does not need to fast before starting the diet. So they can eat a whole variety of food that, basically the guidance can be given by our nutritionists. And in Stony Brook, we have a team of nutritionists that have the experience managing the diet and all the variants. Now, Talking about other diets that have been used also, there is the medium chain triglyceride diet, that what they call the MCT diet, that has been used in some patients, and also diets that have low glycemic index, which mean very low carbs, but it's not as restrictive. And people have been used successfully. So that's basically what it is about the keto diet and the other variants.
Great, thank you. That was great. Okay, so my next question is actually to Dr. Manganas. And basically being a pediatric epileptologist, I wanted to ask you, we have this great children's hospital at Stony Brook with a lot of advanced care, but a lot of people may be curious, okay, so we have this great hospital. How does this great hospital help advance the care of patients with epilepsy, pediatric patients specifically?
Yeah, so I think we have been quite fortunate since the opening of the Children's Hospital in 2018, because I think the Children's Hospital brings everything together, which sounds obvious, but in many places it's not. And having everything in one major center is important, particularly for our children and their families. First of all, our pediatric epilepsy division in and of itself is composed of 6 faculty members, all whom of which are board certified pediatric neurologists, board certified epileptologists. In addition to that, the hospital itself provides the opportunity to monitor our patients. We have at least 8 rooms that are specifically designed for our epilepsy patients, and they're designed specifically with the family in mind. They're modern rooms where families can stay during the monitoring process. Our children are monitored with a live monitor watcher who makes sure, that seizures are visualized, that the equipment is working right, and that we're able to capture everything we're supposed to. We have our pediatric ICUs in the same location, which of course makes monitoring even more efficient. Finally, the team, right? As child neurologists, as pediatric epileptologists, we don't work alone. We work with our exceptional nurses. We work with our neurosurgery team, our neuropsychologists, our neuroradiologists, and we all do it together in the Children's Hospital. So again, I think the Children's Hospital serves a vital function for Suffolk County, the children of Suffolk County, but also neighboring counties, to bring together all the subspecialists in one place with all its advancements, so we can not only monitor children, capture their seizures, assess their seizures, but do the advanced neurosurgical workups that Dr. Blond was talking about, bring our nutritionists together for the diets that Dr. Bello was talking about, and provide the best possible care that we can for our children, knowing that their families play a vital role. And again, designing a space with not only the children, but their families in mind.
Thank you so much. Great. And my next question is actually to Dr. Blond. And along with, state-of-the-art children's hospital, we also have a neuro ICU for the past couple of years that also is state-of-the-art. But I was actually, if you can elaborate specifically when it comes to epilepsy and the neuro ICU and possibly the other ICUs, as to how our patients who actually have seizures, how that global advancement in our neuro ICU and the other ICUs, how did that help, if at all, patients with seizures who are being monitored there?
So I think when we think about intensive care and epilepsy, there's really, I guess, two different scenarios that we think about mainly. When we think about people who have epilepsy, we think about them ending up in the intensive care unit when they're having ongoing seizures that can't be controlled, which is called, status epilepticus. That's a very serious, condition, and it really requires very comprehensive treatment, and you need a team that is very well trained and can act very quickly. And that's where it can be useful to have more support resources from the hospital, which thankfully we have. So some of the things that I'm referencing, having the ability to get patients in to put an EEG on their head, which is the electrodes and wires that help us to monitor the electrical activity in the brain and to determine if somebody's having seizures or not. That is very important for the appropriate management of seizures. And we are fortunate that we have technicians staffing the hospital 24/7 and can always, hook up a patient that we're concerned is having seizures and help us manage them right away. And we have very highly trained nurses and physicians and intensive care experts and respiratory therapists and a whole team that is involved in getting to patients quickly. One of the most important things when somebody comes into the hospital and is having seizures that can't be stopped is treating them in a timely manner. We know that for people whose seizures are not under control and are ongoing, the longer amount of time that they continue to have seizures, the harder that it will be to stop them. And so it's very important to have the right hospital resources backing up your medical care to make sure that things happen as they're intended. And so I think for anybody who has epilepsy, that should be comforting, that if you do end up in a situation where you're having very bad seizures, you know that there's a hospital in the area that can bring you in and treat you in a timely fashion and give you the best chance of success. The other main thing that we think about with intensive care units and epilepsy care is that many people who are critically sick can have seizures, not necessarily because they have epilepsy or that they will have epilepsy when they go home, but because of the severity of the illness that they have and the impact that it's having on the brain. And that is another area where specialized training in epilepsy and EEG can bring better care to patients. And that's most common in the neurologic intensive care unit where people are having an acute injury to the brain. And we have a number of hospital beds that are specifically set up so that that monitoring can happen quickly and efficiently and be checked in on live at any time. But it is something that can happen to people in medical intensive care units and surgical intensive care units. And that's a part of care that we're involved in. I think the last thing to mention in terms of our work with the intensive care units is we're fortunate to have a partnership with our pediatric intensive care unit that not only involves our monitoring of children who are acutely sick in that moment or having seizures, but also as a part of the care for our epilepsy surgery program. As we were talking about, epilepsy surgery is very complicated. When we are fully working somebody up and considering surgery, we'll actually do a type of surgery where instead of putting electrodes and wires on the outside of the head to monitor seizures, we'll actually place electrodes on the surface of the brain itself or sometimes deep in the brain. And that can be a very complicated procedure. And for children, we actually keep them in the intensive care unit throughout their stay to make sure that they're having the highest level of nursing care and attention paid to them, and making sure that there's multiple physicians involved to make everything go as smoothly as possible.
Very good. Thank you so much for that, Dr. Blond. Great. The next question actually I have is once again to you, Dr. Bello. We are blessed to have you and also Dr. Cruz, who are bilingual and specifically in Spanish. And we do have a Spanish community here in Suffolk County, in Long Island. And I was just wondering, actually, how do you see being able to speak Spanish to your patients and families when needed? How is that helping the Spanish speaking community here, specifically having physicians who are bilingual?
Okay, thank you. Yeah, it has helped a lot. I mean, in general terms, there are more than 700,000 people with epilepsy in the United States. And despite like the prevalence, people don't completely understand in the Hispanic community sometimes about epilepsy. So we're able to provide in their language some more understanding about this condition. Although epilepsy can affect everyone, and the minority communities have less access to specialized epilepsy treatment and care. And we are privileged here to be able to provide with material and explain in their own language about this condition. It is challenging. Culturally, we have to give the appropriate education and resources for people with epilepsy, and they should know that we are available here and we provide the care for a patient with this condition, that the appropriate care that is needed for them. So we have been successful to treat many patients in our practice with this condition. We offer also during the visit material in Spanish to the families to better understand about epilepsy.
Great. And I know that is very, very useful. So thank you.
Right.
Great. Thanks for explaining that. Okay. And actually, Dr. Bello, there is a great feed. There's another question, if you don't mind. I'm seeing it here. And the question is, are there other conditions that may mimic epilepsy? If you don't mind.
Yes.
Yeah.
Yes. There are many conditions that can mimic epilepsy and depends on the age. Basically, in the pediatric age, there are certain things that not necessarily are related to epilepsy. And, we have one of the most common things that we see in our daily practice are syncopal episodes, what we call in plain English, the fainting episodes. But there are many other things that involve loss of consciousness that can mimic an epilepsy. Again, as I said at the beginning, one episode of loss of consciousness doesn't mean necessarily that it's a seizure and doesn't mean necessarily that is epilepsy. So that's when all the diagnostic resources play a role. There are episodes that include stirring spells, that it's when the children stir off in the space, and that can be related to behaviors. Also, we have what we call breast holding spells and childhood, and abnormal involuntary movement that are not necessarily related to epilepsy. Now, there are what we call non-epileptic seizures that are related to events that are not necessarily related to organic cause. And the studies basically are essentially a negative and can be related to a psychological cause. Now, probably Ben can elaborate a little bit more on the differential diagnosis in adults that are completely different in our pediatric population. But again, it requires the evaluation of a specialist, the pediatric neurologist, and epileptologist when the symptoms are more complex.
Great. Thank you for that. Okay. I also wanted to ask Dr. Manganes about clinical trials at Stony Brook, and if you can elaborate on those.
Sure. So Stony Brook obviously is known nationwide and throughout the world as a science, quote unquote, science school. Our strengths are basic science, physics, chemistry, math, the life sciences. And a lot of that translates over to the medical campus, where we perform clinical trials, not only drug clinical trials, but diagnostic and biomarkers as well. As many people know, imaging is our strength. The MRI was discovered right here at Stony Brook, and the very first MRI is in our chemistry building. So we use imaging modalities for many of our trials, many of our clinical research type of experiments and trials. There are many trials that we conduct, whether they are industry sponsored or investigator initiated. There are many trials in the department that again are funded either by industry or investigator initiated. Most of the industry funded studies that we participate in are drug trials. A lot of the more interesting and sort of outside of the box type of studies that we do are investigator initiated, and they really focus around the modalities that we use for diagnostic purposes. For example, EEG, MRI, and genetics. So for example, there are ongoing studies now looking at EEG findings and signatures for children who have autism and epilepsy, being conducted in collaboration with Dr. Miller-Horn in our division and Dr. Lerner in psychology. There is also in collaboration with our neuropsychologists, there are genetic studies through the Autism Initiative, which are trying to understand genetic mutations and genetic changes in children with epilepsy and autism right here on Long Island. And we continue to recruit in those studies. There are imaging studies looking at being conducted in my lab, looking at children who have epilepsy, using imaging to try and identify stem cells in the brain and how they may be contributing to children who go on to have seizures in the future. So there are many studies that we encourage our patients when we see them in the outpatient clinic and the inpatient clinic. We talk about our studies and the benefit that they will have, not only now, but in the future. And so we through the Neurosciences Institute and through the Children's Hospital, try to inform our patients about the studies that are ongoing and encourage them to enroll if it's something that they find interesting.
Great, thank you for that. Great. Dr. Blond, I have a question for you, and that is actually about our support services to our patients. What support services, other than just the typical clinical support services that we have elaborated on, do we have available to our patients?
Well, one of the things that we have available is that we do run an epilepsy support group, here at Stony Brook. It's actually run by some of our resident physicians, and it meets once a month on Thursdays. And oh, great! And they put the number up for you if you want to call to find out about joining the group. It's a very special group, I think. It actually combines all of our epilepsy patients here at Stony Brook. So I have patients who are adults and patients who are children who both go to the group. The children, go with their families. And I've gotten really good feedback from the patients that I have who have been in it. Epilepsy, as I was saying earlier, can have a major impact on people's lives, and it can be very helpful to get to meet other people who are facing some of the same challenges and learning ways to adapt. And it can also be helpful to be able to have a discussion with healthcare providers that really focuses on some of the practical aspects or other things that patients just really want to know about what it means to live with epilepsy, and to be able to talk about things in a group environment that isn't sometimes as limited to what you may have in a regular office appointment with your doctor to and to just have that emotional support. I think that's something that people have really benefited from.
Great. And I also, along with that, we also have the Epilepsy Foundation that we are in close collaboration with, do a lot of activities with them. And that's another source, obviously, that our patients can use as well. So thank you so much for that, Dr. Blond. I know our time is coming up, but I do see a question, and we're going to try and address that. There is a patient who actually specifically is telling us that if seeing quote unquote purple blobs in the vision, could that potentially be epilepsy related? It looks like the person did go to an ophthalmologist. So we have to be a little careful. We don't know the full story, but in general, seeing purple blobs or colors and so forth, could that possibly be epilepsy related? And actually, Dr. Blond, if you can actually comment on that, if you don't mind.
Sure. So I think one of the challenges with epilepsy is that there's so many different types of seizures, and so it can present in many different ways. And we often get asked that by people and their families and by other healthcare providers of when should we be thinking about seizures. And it's a tough question to answer because the symptoms can be so different for different people. But some of the things that we look for is anything that seems to happen in a characteristic way. That is, when it happens on a particular day and then happens on another day, that it really happens in the same way. The person experiences the same thing. So let's use these, purple blobs as an example. If a person is seeing a purple blob in their vision and it's in the same relative location in their vision each time, that would be something that would be more suspicious for a seizure. Whereas if it was purple one day and green the next day, that would be less common for a seizure. Seizures tend to cause the same symptoms when they happen again. And the time frame of symptoms is also something that can help make us suspicious, for seizures. A typical seizure lasts between 30 seconds and about 2 minutes. There are certainly seizures that are shorter and longer, but that would be the most common time frame. And so symptoms that happen in that time, may make you more suspicious, for a seizure as opposed to other things. But anything that seems like it could be a product of the brain. So for example, a person seeing something in their vision and they saw an ophthalmologist and they didn't see a particular problem in the eye that would explain it, that could be a good reason to see a neurologist and be further evaluated and see if there may be an explanation that's related to seizures or perhaps another neurologic condition that might mimic it. There's nothing specific that would make you suspicious for purple blobs in vision and epilepsy. That wouldn't be a common seizure type by any means, but could be worth further evaluating if you're not getting other answers.
Great. Thank you so much. That's great. I know we are close to wrapping up. Actually, perhaps one more question, and I will actually give that to Dr. Manganas. If Dr. Manganas, if you can briefly also discuss possible supplementations that our patients may benefit from along with their medications.
Yeah, so supplementation, I think, is something that's important to discuss across a wide range of age groups. For example, folic acid, particularly in women who are of reproductive age, but even younger women as early as puberty. I will have the discussion about supplementing with folic acid, particularly if they're taking antiepileptic drugs. We know that antiepileptic drugs or anti-seizure medications can cause neural tube defects. So neural tube defects are refers to a term that we use when we think about the developing nervous system. The nervous system develops primarily in the first trimester during pregnancy, a time when some women may not know that they're pregnant even. So even more importantly, it is important to discuss and promote and educate young women and women who are thinking about planning a family about using folic acid, because folic acid will prevent neural tube defects or any problems or issues with the developing nervous system. Folic acid is required for the nervous system to develop, and sometimes the medications that we use in epilepsy can interfere with that process and cause what we call neural tube defects, deformities in the spinal cord, deformities in the brain during that first trimester. So it's important to start educating early. Like I said, I start educating and promoting folic acid usage at the time of puberty. Later on, particularly in the elderly, supplementation with vitamin D and calcium is important. A lot of these anti-seizure medications can interfere with calcium and vitamin D. So it is important to routinely do vitamin D levels, particularly in the elderly, to make sure they maintain strong bone health as well as calcium. So these are things we talk about at every visit.
Great. Perfect. Okay. Guys, it was great. Thank you for answering all these questions. And at this point, we are going to be wrapping up. So if anybody else wants to put anything in the chat, put your email if you can, so we can try and answer offline. But otherwise, this live stream is coming to an end. It was truly a pleasure. Thank you, everybody, for participating. Okay.